Okay, welcome. My name's John Kramer. I'm an associate professor in the Department of Anesthesiology, Pharmacology, and Therapeutics in the Faculty of Medicine at the University of British Columbia, and a principal investigator and associate director at the International Collaboration on Repair Discoveries, which is a center dedicated to research in the area of spinal cord injury. And it's my pleasure to talk a little bit today about neuropathic pain after spinal cord injury. And what I've tried to do with this particular presentation is highlight where I see opportunities for investment in the research space in neuropathic pain. So overall, or generally speaking, it's a really exciting time for pain research. This came to lots of people's attention by way of CNN when Dr. Gupta here is reporting on the FDA's first new pain medication or non-opioid analgesic in the last 25 years. So this got a lot of attention and headlines, and rightfully so. This was many years of investigation. It actually comes from dating back to clinical trials in 2023 in acute pain, and particularly post-surgical pain. And you can see here in this particular study, they're showing just the numeric pain rating scale here on the y-axis, and then 48 hours post-injury, and their primary analysis is comparing to a placebo condition. And you can see over that period of time, there is a reduction in pain in the VX548 treatment group relative to the placebo group. So this was really important, big finding. And also you can see here in the inset over a 4-hour period where the pain was measured and reduced during that important period post-op. So this is very important for acute pain. And what was actually even perhaps more important from the research perspective was how VX548 came to clinical trials. And really what happened there was a study focused in human biology, which was one of the first times this has happened in this particular field. The typical translational path for analgesics had always gone through animal models and animal testing, and then into humans. For VX548, it starts a little different. First, it's an understanding of congenital insensitivity to pain and a mutation in the SAC10A gene, which led to changes in the NaV1 1.8 channels. Then further characterization of NaV1.8 in these human postmortem dorsal root ganglions. And then ultimately into clinical trials. So it went a very different path ultimately, and one, for example, that was very different than what had been kind of failures in the past, like NK1 antagonists. So this was really an exciting period, or is an exciting period for pain research. How much of a problem is pain after spinal cord injury? Well, I want to convince you, and it probably doesn't require too much convincing for anyone with knowledge in the space, that neuropathic pain specifically is a very substantial problem. This is a reflection of the quality of life here on the y-axis, and this is a particular study that was done out of Denmark. And you can see here with almost all domains of quality of life, life and life situation, physical health, mental health, you can see a stepwise reduction in their quality as you have an increase in score in their DN4 score. And their DN4 score is a standardized way of characterizing pain and neuropathic pain specifically. And really, you start getting into neuropathic when your DN scores are in this 3 to 7, or represented in the black bars here. So you can see here really in at least 2 of these domains, mental health and life situation, it really takes a step down, and it has a very negative effect when this pain becomes neuropathic. And that's due to a variety of factors. One being the severity of neuropathic pain relative to other forms of pain, as well as its refractory nature to interventions. So without question, neuropathic pain after spinal cord injury is really an unmet medical need. What exactly is neuropathic pain after spinal cord injury? Well, it's a form of central neuropathic pain. There's a variety of types of central neuropathic pain that can be kind of clumped together. One would be stroke, in this kind of classic one-sided nature of pain that you see with stroke. as well as MS, which is a little bit more diffuse, and then spinal cord injury here represented in the middle. And what you typically see with a spinal cord injury neuropathic pain is what's described in the field as below or at level neuropathic pain. And where that becomes important is that it has to be neuroanatomically plausible in relation to where the injury is. So if someone with a thoracic injury has pain up in their upper extremities, well, we don't really think that's central neuropathic pain in the classical sense, or at least that's related to their injury, but could be coming from other sources. In the region where pain, central neuropathic pain exists, you have sensory loss and other features such as allodynia. So this allodynic perception of when light touch becomes painful. This is a classic sign of neuropathic pain. The real trick in the case of spinal cord injury comes in distinguishing central neuropathic pain from other types of pain. So, of course, when you have a spinal cord injury, there's other varieties of pain. Nociceptive pain. There might be pain related to bowel routines, for example. And what becomes the challenge in diagnosing central neuropathic pain is distinguishing it from these other types of pain. So there's a variety of mechanisms we think that underlie neuropathic pain. Really, the chief of which is this neuronal hyperexcitability, increased neuronal responsiveness, spontaneous neural activity, all of which give way to the evoked signs of pain. So, like I already mentioned, allodynia, as well as that spontaneous signs or symptoms of pain, which is really just pain that's there all the time. How pain develops after spinal cord injury is, I think, really important, and I'm going to come back to this as to one of the opportunities for investment. And we've learned a lot about this in recent years, and it's actually pretty difficult to characterize, particularly in the acute phase. Asking or figuring out whether pain is neuropathic or nociceptive or any other type of pain in the acute phase is obviously challenged by other comorbidities in that really early period. And that really early period here I've marked as 5 days post-injury. But when we've tried to do this, the best estimates we can really come up with is about 25% of people in the very early stages after spinal cord injury will have neuropathic pain. This is predominantly at level, and there might be a reason for that, is that when the traumatic injury happens, you may have some peripheral damage in the segments close by, and this would really account for that immediate onset of neuropathic pain. So you can almost consider that a form of peripheral neuropathic pain in the conventional classical sense. But we know that from that 25%, some will ultimately lose that neuropathic pain at a later chronic time point. So 3, 6, 12 months post-injury, they'll ultimately lose it. And then some who didn't have it very initially will develop it over time. And this develops in two varieties, both below and at level. So below meaning that the pain is far below their level of injury, and at still remaining at the or close to where the actual injury is. What's really important here is that actually pain is, we think now, much more dynamic. It used to be perceived as somewhat stable, and it would either come on very early and then persist for a lifetime, or develop for a lifetime and then persist. But this dynamic nature of neuropathic pain after spinal cord injury is ultimately something very important, and that characterizes the entire condition. Interventions for neuropathic pain, there's a few, many which people would be familiar with. So frontline pharmacological interventions are typically involving gabapentinoids and then serotonin, noradrenaline reuptake inhibitors, and then as well as the classic tricyclic antidepressants. We get into second line interventions as well, and you're into capsaicin and lidocaine patches, and ultimately this is where opioids will fall as well. Alternatives to pharmacological intervention are really lie in cognitive behavioral therapy and then the emerging world of neuromodulation. Just to highlight the market and the consumption of gabapentinoids, and when we really talking about neuropathic pain and spinal cord injury and the pharmacological management, really the frontline choice is still gabapentinoids. And you can see and is really $1 billion market when you talk about gabapentinoids. I think there was something like 7 million prescriptions in the United States related to GABA or pregabalin specifically in 2022. And you can see there's really, since coming into the market, there's been a steady increase in gabapentinoids dating back to 2002. This is now a little bit outdated into 2015, but I think this is just continuing to track upwards. So really, gabapentinoids have really increased, and this probably relates obviously not to the market related to spinal cord injury, but more in relation to the use of these drugs for other things. And there's some concern, for example, that these are now being used for acute pain, where they've certainly shown a lot less efficacy in comparison to neuropathic pains and chronic pains. We've seen this in spinal cord injury as well, in how we've seen changes in prescribing of gabapentinoids. This is actually showing it in the very acute period. So you can this particular line here is back to 2010, 2011, and then there's been a really consistent increase up until 2019, and this just shows the cumulative overall percent. So really in recent years, in 2018, 2019, we're getting upwards of 90% of folks in the very acute period within 10 days being prescribed a gabapentinoid in their acute hospital stay. So the opportunities for investment in neuropathic pain after spinal cord injury, I'm going to lay out 5 here. And one, while I've gone through some of the frontline interventions for neuropathic pain, we really have to keep in mind that the neuropathic pain, as I somewhat already alluded to, really remains largely refractory. So these are the actual clinical trial results from the 2 pivotal studies, 2006 and then in 2013, that were used to get approval in the space of spinal cord injury in relation to pregabalin. And you can see in 2026, you have just under 7 starting point for their pain rating, and it's dropping just above below 5 in the pregabalin group, and then a minor decrease in placebo. And you see a similar change in the pregabalin group in the later study, but a larger placebo change. These were significantly different, and they were driving the overall beneficial effect that is now seen for spinal cord injury neuropathic pain. There are some other notable things to highlight in these particular studies. Less than 5% dropout rate to adverse events. So this was, the side effect profile was deemed tolerable. And you actually saw some, in terms of secondary outcomes, some very, what would be larger effects, although perhaps not initially planned for those secondary outcomes, particularly in relation to sleep. And now there's been quite a bit of science related to the improvement of sleep architecture related to gabapentinoids. So this, and what I would really like to highlight here is that while we have effective pharmacological interventions, there's still a lot to be done. I mean, you can see in both these cases, folks hovering around 5 out of 10, which is still a rather severe amount of neuropathic pain. It's also true, I didn't want to just highlight the pharmacological interventions and non-pharmacological interventions. This is from really the landmark clinical trial that was done for cognitive behavioral therapy. Measurement 1 at baseline, measurement 2 immediately at the conclusion of cognitive therapy. And then you can see at the long-term follow-up, 3 months following cognitive behavioral therapy, pain intensity in the treatment group here highlighted in the black line, and then the control condition here in the dotted line. Ultimately, it just is rebounding back to what you can ultimately achieve in a control condition. So the effects of the better pain management aren't sustained over a long period of time. So really, there's an important need for better interventions. The second real need for investing in the management of neuropathic pain is safety concerns. And while the safety concerns related to pregabalin have been fairly well defined, obviously, as I suggested, the drug is well used, so we know quite a bit about the adverse event profile. There's still concerns related to its really long-term use, and this is where I think spinal cord injury becomes an interesting area to study because these are people who are often very young starting on the drug and then can persist for very long periods of time. So you have really long exposure periods. I'm really interested in the kind of bioinformatic approach, and this is one where you're using bioinformatics and specifically data from the Lynx 1000 to predict unlabeled adverse events. And one of the top unlabeled adverse events when this data originally came out uh, was concern for embolism, and that obviously gets some amount of concern when you talk about people with spinal cord injury, particularly in the acute phase, which are prone to these types of events. So this is identified as a concern, and actually very recently. In 2022, more concerns related to the chronic use of gabapentinoid and pregabalin was identified in diabetic neuropathy. And you can see this increased risk of DVTs in this particular patient population. So the long-term exposure in spinal cord in folks with spinal cord injury who are already at risk of other comorbidities is unknown. This is something we're very interested in following up and identifying any concerns that we may have. But this again highlights that the overall safety concerns remain a problem, and there's really a need for alternative interventions. The third uh, area of opportunity for investment relates to what I'm highlighting here is multiple opportunities to intervene. And there's the classical experiment of folks with chronic neuropathic pain after spinal cord injury and then intervening in that chronic phase, hoping to reduce their pain. But as I already suggested in the earlier slides, where we have pain developing over time, and this is just highlighting that if we have an initial injury here, there might be some amount of pain that subsides, but it's this development that we're ultimately concerned about. So in this development, if we start understanding the mechanisms of how this is developing, what we have in the case of spinal cord injury is a window of opportunity for chronic pain prevention. And this is a big area of study. It's really been most explored in chronic post-surgical pain. But I think in the case of spinal cord injury, you also have another opportunity to investigate that. Number four, one of the primary reasons that or one of the primary areas of study that my lab is interested in is identifying biomarkers of chronic pain. And here there's actually a fairly obvious target for a biomarker. Unlike a number of other areas in the field of spinal cord injury where we've really struggled for biomarkers, in the case of chronic pain, we can look to the brain. So the brain obviously is where pain is ultimately processed. So looking for changes in structure, and that's what I'm showing here in these figures. You don't need to dive too much in the details, but what we're ultimately trying to understand is the relationship between pain on the x-axis here and then features of cortical anatomy in thickness and volume and curvature, and how they relate to the amount of pain someone experiences. So the hope here is when we identify a good enough biomarker here or a combination of biomarkers, that ultimately when we change pain in early phase clinical trials, we can then of course drive changes in these biomarkers as validation that we're having the anatomical and physiological effect that we're hoping for. Finally, I don't think when you're targeting pain, you shouldn't consider that you're also not improving other functions. So we've been very interested in the last number of years to understand how improving pain through the pharmacological management it ultimately leads to benefits in motor recovery. So it's that these two important outcomes after acute spinal cord injury are not mutually exclusive. And we've done that. We've been really interested in the use of anticonvulsants, specifically gabapentinoids. And what I'm showing here is some work from the European multi-center study about spinal cord injury. And we've found that those who were administered acutely gabapentinoids, they tend to recover better. And there's a number of reasons why they might recover better. One is that their pain is ultimately better controlled, and if their pain is better controlled, then they're able to ultimately have the gains in function. There's also some mechanistic links with some of these pain medications and regeneration that are being explored more on the basic side. But I think really the important message here is that we can ultimately, by improving pain management, lead to gains in other areas that are important to people with spinal cord injury. This is actually can go in the reverse as well. So this is from work from Michelle Hook's lab that's highlighted the deleterious effects of opioids on motor function. So in this particular case, the opioids are delivered 7 days post-injury in a rat model of spinal cord injury, and this is just their behavioral outcome. And ultimately, the control group that does not receive the opioids versus those that receive opioids does better in the long run. And this is obviously a concern because the opioid use in the very acute stage in the human condition is very common, obviously in the case of controlling and managing acute nociceptive pain. So here's another opportunity, not in the case of introducing pain management, but perhaps non-opioid alternatives to manage pain, which could then again unmask improvements in motor function. So I'd like to end there and just a quick summary. I think there's new and emerging therapies for pain that have been recently reported and entered the market, and this is driving a whole new area of research. And we're going to see in the coming months how some of these new targets do in the case of managing chronic neuropathic pain. Neuropathic pain really remains a huge problem for people with spinal cord injury, and investment in this area has the opportunity to resolve major deficits for those living with spinal cord injury. And I think there's unique opportunities to conduct biomarker informed, which obviously, the inclusion of these biomarkers has a huge advantage in clinical trials. We know that. And ultimately testing these novel analgesics in early phase clinical trials in individuals with spinal cord injury. So I'll end there by thanking all the folks that have graciously supported the project, as well as my many, many collaborators that I don't have time to thank all of them, but you saw some of them on the slides. And thank you very much for your attention. And I hope if anyone's interested, they might reach out and we can start a dialogue. Thanks very much.